Hi, my name is Dr. Justin Hughes and welcome to the Sport Doctor webinars. I'm delighted to welcome consultant vascular surgeon, Professor Ian Loftus. Professor Loftus is going to speak to us about the vascular causes of exercise-induced leg pain in the younger athlete. Exercise-induced leg pain is a common presentation amongst our active population, the common causes of which are often bone or muscle-based pathology. We know the differential diagnoses here include referred pain, bone stress reaction or fractures, chronic compartment syndrome or muscle injury. A less common cause is vascular, and less common means by definition that we see it less and probably therefore know less about it. Professor Loftus is a true expert in this area. He's a consultant based at St George's Hospital in London, and he has published over 300 papers, over 30 book chapters, and presented over 200 papers to meetings nationally and internationally. He acts as an advisor to the National Institute of Health Research and sits on the Royal College of Surgeons Research Board. He was president of the Vascular Society of Endovascular Therapy and president of the Vascular Society of Great Britain and Northern Ireland. You'll agree, a true expert, and I'm very grateful for this, for him being here this evening. We're planning a 30-minute talk and a Q&A session afterwards. Professor Loftus, that's a seriously impressive CV. I'm really pleased you're here this evening to impart your knowledge. Good evening and welcome.
Justin, thank you very much, and thank you. That's extremely kind introduction. I developed an interest in these conditions quite a long time ago for the reason, Justin, you just touched on, which is they're often unrecognised. And I saw a lot of people going through the mill for 3 to 5 years before a diagnosis was reached. So I wanted to sort of touch on a few of the things I see commonly, but I think are not seen perhaps as commonly this evening with this talk. I'll just share my screen. Hopefully you can see that. On the vascular causes, you've touched on the musculoskeletal causes, so I'm not going to talk about those because you know about those far better than I do, but I just want to go through the causes that I see relating to the compression of the vasculature and occasionally the nerves and other related conditions, how I think we should assess and investigate them, what the role of surgery is, and what there is in terms of outcomes from the literature. And I will say a lot of it is rather sparse, but I'll touch on each of the conditions in a little bit of detail of what there is in the literature. And these are the conditions to be aware of. I think you see these sports people, not just professional, but active sports, young people, and even peripheral vascular disease is worth considering in some of these. I won't talk about that in a great deal of detail, but just touch on a few of the bits around it just to be aware of. But the conditions I'm particularly interested in are endofibrosis, popliteal entrapment syndrome, and compartment syndrome, and I'm sure you know there's some overlap there, and also just finally popliteal adventitial cystic disease. So I'll touch on each of these in a bit more detail. And what I would say is to discriminate between these vascular causes and the musculoskeletal causes. The most important thing is the history for me. So I take a lot of time with patients now to get a really detailed history of exactly what the pain is like, precision around what brings it on. So is it the same every time they exercise? Does it vary? Does it affect one leg more than the other? The precise location where it starts and where it spreads to. So where does it radiate to in the leg? Neurological symptoms, I think, are key for one or two of these conditions, which I'll touch on a bit later, and also discoloration. So I often ask them, do you take your socks off? And do you look at your feet? And what is the colour of your feet? What happens to them? The type of activity is really important. Again, I'll touch on that as I go through each of the conditions. And for peripheral vascular disease particularly, it's really important just to touch on some of the risk factors, not just of the individual, but of patients. Now, sports people in general, you know, very few of them have significant risk factors for peripheral vascular disease, but I still think it's worth quizzing on those, especially family history. So people with a strong family history of cardiovascular disease, it's still worth considering that in even people in their 30s and 40s. And again, the key is the history, but some examination and some simple tests just to look for it. Again, I'll touch on that as I go through these tests, these conditions. The one I want to start with is endofibrosis, perhaps the most missed condition. And it's missed by all of us, actually. So all medical professionals miss endofibrosis because it's unrecognized. We didn't know about it 15 years ago. There's still very little known about it. But if you go on the internet, you can find quite a lot from the professionals, so i.e. the professional cyclists. So really high-end sports professionals, particularly cyclists, are fully aware of iliac artery endofibrosis. So these are the sort of websites. I had to put a picture of me on here, just I'm clearly not a professional cyclist, but it's just a weekend hobby. So I'm never going to get endofibrosis. And again, there's another one, Cyclists Iliac Syndrome Interest Group. People in the know have a great deal of knowledge about what this condition entails. If you want to know a bit more medically about this, this is the paper I would reference to you to go to. So this was a paper by my colleagues at St George's and elsewhere. You might recognise one or two of the names. Rob Hinchliffe, who was a colleague of mine at St George's, now works in Bristol, had a particular interest in this. He was a very high-end cyclist and developed a particular interest in this condition and wrote a review article published in the European Journal of Vascular Surgery some 9 years ago. The literature really hasn't changed since then, so for me this is the paper to go to. And here are some of the facts around endofibrosis. It's a condition of intimal thickening of the iliac artery, and very specifically of the external iliac artery. It's almost always very high-end or professional cyclists. So this is the sort of average distance. If you actually ask people their distance of cycling, these are not weekend cyclists like me. But I think what's more important is the intensity of cycling. So if they do really fast sprint cycling, so short periods of high intensity cycling and high intensity uphill cycling, that seems to be the key. It seems to be much more common in young men, is usually unilateral, can be left or right side, and as I said at the start, usually the external iliac artery. And there are some factors that seem to predispose to it. So position on the bike seems to be key. Hyperflexion of the hip, but also an association with unusual looking, long, tortuous iliac arteries. And I'll show you an illustration of this. They also, perhaps not surprisingly, have significant psoas hypertrophy on scans. And the external iliac artery seems to be relatively fixed by the musculature and the tissues around the artery. There's some suggestion, but absolutely no evidence base for this, that there may also be some associated metabolic and endothelial dysfunction, but that's very much unproven and I think will always be impossible to prove. The symptoms are key here, and for those of you that have seen patients with this, it is quite interesting because they complain for quite a long time of a very gradual and progressive reduction in their power and of fatigue in the affected leg, and very much unilateral. That's the key. So it's very different to a lot of the other conditions that these guys get. It comes on often as a cramping, more often in the thigh than anywhere else, but can, if they continue to exercise at high intensity, spread to calf and buttock, and often associated with some paresthesia and numbness and a feeling of swelling in that affected part of the leg. What's key in the history is that it only comes on at maximum exertion and is relieved very quickly by rest. So they push themselves very hard, they get the symptoms. If they slow down or back off on that maximum intensity, it goes off. So it's not a pain that stays with them for a long period of time. There's description of hearing a femoral artery bruit, but only when they flex and get into that extreme hyperflexion in the hip position. How reliable that is, I really don't know, but you wouldn't hear a bruit in a fit young patient without something wrong with their blood vessels. And as I touched on earlier, one of the problems here is they often delay the diagnosis often very, very late because it's not recognized. And it's quite hard to diagnose. So again, the history is key, but duplex ultrasound is really important, but it has to be done the right way. So me carrying a portable ultrasound around is not enough. These have to be done on high-end ultrasound machines with vascular ultrasonographers who understand the condition. And in particular, you have to do it before and after exercise. So we put them on either a treadmill or actually on their bike, ask them to bring a bike and put it onto a spinner and get them to exercise at high intensity. And that's often the way you can diagnose this. You can also do MRA and hip flexion and other things which are perhaps not as helpful. So I won't touch on those in too much detail, but the key is the duplex ultrasound, which I'll show you an illustration of. So the first thing is, in hyperflexion of the hip, you see this extreme kinking of the iliac artery. I don't know if my arrow will show this here, but you see this really extreme kinking from a resting position, which looks normal, to this almost complete U-bend in the iliac artery. That's not normal. But then what's key is when you get these people to exercise, you see a difference in the flow. So this is looking at Doppler flow velocities in the artery, where here on the right side in the external iliac artery after exercise, you get this real damping of the blood flow instead of the normal left side where you get this normal triphasic, very high peaked waveform pattern. So this is clearly very abnormal, and that's the key to the diagnosis. Even if the ultrasound of the blood vessel looks relatively normal, if the flow changes that dramatically on exercise, it's not normal. So what do we do about it in terms of management? Well, conservative is probably the first thing, but a lot of these people don't want a conservative approach. But there are potentially changes you can make, especially in the non-professional, to the bike position, to minimize that hyperflexion in the hip and perhaps take a less racing line on the bike. Clearly, intensity of the training. So again, someone who's perhaps not a professional cyclist, you can suggest that they just change the intensity of work they're doing. There is absolutely no role for endovascular approaches to this. So stenting is out, because if a stent blocks in an artery, that's a disaster in a young fit patient, and they kink. So they continue getting to that hyperflexion position. They will kink their stents and occlude them. There is a role for surgery in extreme cases, but I think they have to be very selective and very much the higher end cyclists and athletes in whom it's really causing them significant problems. And there is an algorithm. The paper I referred to from George Peach and Rob Hinchliffe back in 2012 has a really nice management algorithm for this, which I'll just show over 2 slides. So again, it touches on the importance of the physical examination and the history. So that plus a duplex ultrasound is really the key in making the diagnosis. Obviously, if they don't fit, we need your help in this. We need physiotherapy, sports medicine, orthopedics, neurology, whichever is the more relevant. But then once we've made what we think is a diagnosis, we do MRA routinely in a standard position and in a hyperflexion position, very occasionally angiography, again in different positions. But then we have different options in terms of the surgery based on what the vessel looks like. And this can be simply releasing the artery from being trapped. It can involve shortening of these hypertortuous vessels. It can include patch angioplasty to actually open up the vessel and patch the vessel with the patient's own long saphenous vein just to widen it, or very rarely actually interposition grafting of the artery if it's severely affected. So a number of options, and each patient just needs a very careful workup to know whether each of these are appropriate for their individual situation. This is what the artery can look like. This is a picture borrowed from Journal of Vascular Surgery. This can look very normal on a standard ultrasound and on standard imaging, but you can see from the inside of the vessel it's clearly very abnormal. And in a normal individual, probably wouldn't restrict blood flow, but in someone who's exercising high level, that's enough to cause significant problems. Outcomes, no trials here, and really we base what we know on case reports. What we do know from our own experience of operating on these, it takes 6 weeks to recover, probably 12 weeks to get back to high level activity. Complication rates are low, less than 10%. And about 3/4 get back to that normal high level of activity. So it's not perfect, but for people in whom it's their livelihood, there is certainly a role for this. So that takes me down the leg to Popliteal entrapment syndrome. I have a particular interest in this condition and wrote this paper some 9 years ago, so around the same time as that paper on iliac endofibrosis. And the interest really was from links with Headley Court and the Military Rehabilitation Centre there, we saw a lot of this condition through the military. And again, this is probably the most recent, I know it's 9 years ago, but the most recent review of the literature. So I'll direct you to that if you're interested in looking at this more detail. This was back in 2012, Journal of Vascular Surgery, some 290 odd articles. Here's a few things we picked up on it just from the literature and our own experience. It's mainly young people. There are a lot of unknowns. There's a complete lack of consensus among certainly vascular surgeons as to how you manage it. But from the popliteal arterial entrapment syndromes literature, it's young. So the average age around 32. It's more often men and around 40% bilateral. There is a venous entrapment syndrome, which seems to affect younger and more female, but this has a significant overlap with what we call functional or physiological entrapment. And that's where I have a particular interest. This is usually bilateral, usually very fit, healthy, active people with no other medical problems at all. If we touch just on the anatomical types first, these are not the physiological or functional ones. These are the defined anatomical abnormalities. There are 4. There's type 1 and type 2, which essentially are the artery goes the wrong way around a medial head of gastrocnemius. And then type 3 and 4, which involve either an accessory slip of gastrocnemius or a popliteal muscle that entraps the artery. And I saw one of these last week. I've got a video of his duplex to show you, but I haven't got any intraoperative images, unfortunately, because he didn't want me to show them. But this classical type 4, where you have a popliteal muscle band or fibers going right across the artery and trapping it. But the functional one, I think, is really important to try and understand, because these are really badly diagnosed and badly managed. And often, I think the average time I see these people is 3 to 5 years from presentation and the start of their investigation pathway. Again, this is a good paper to look at. It goes back to 2009, but William Turnipseed from Wisconsin has the biggest experience of this condition in the world and wrote a paper of 800 plus patients. So it's really worth a look, even though it is from quite a long time ago. And I've learned quite a lot from his paper here on my practice. What are the symptoms? And this is key. So claudication, it is classical claudication in the posterior calf. So it usually comes on as posterior calf cramping, but often as they continue exercise, they get intermittent paresthesia going down into the sole of the foot. It's a tightness. It's usually reproducible, but not always, but often comes on around the same time, whatever exercise is doing. It's usually running, actually, but it's usually reproducible and is usually very fit people. We saw it, as I said, a lot in armed forces, and I think it's related to the kind of exercise they were put through. Occasionally, it can cause an acute limb ischemia. I've seen one in the last year with an acutely thrombosed popliteal artery, but much more commonly presents with this chronic development of symptoms. And often it is very difficult to make the diagnosis. The key, as I said again, is the history, but with duplex ultrasound. And I'll show you what that shows us in a moment. MR is also vital, and I do it as an MR angiogram, and that will show us those type 1 to 4 anatomical abnormalities with the abnormal muscle, along with the involvement of the popliteal artery as it comes through the popliteal fossa. Exercise ankle breaking pressure index, I do routinely. I don't know how helpful it is, honestly. I think the MR and the duplex are far more helpful. Compartment pressures are tricky, as you all know, but I think in some people it's important to do alongside these things to rule out associated compartment syndromes. And I occasionally do a direct angiography as well. This is the duplex ultrasound. I'll run this through because this is absolutely key to making the diagnosis. This is my patient from last week. So if you watch this, shows the popliteal artery here with normal flow at rest. And as we put the patient into plantar flexion, you can see the medial head of gastrocnemius here pressing down on the artery and completely occluding flow. So there is zero flow going through that popliteal artery and the popliteal vein. And you can actually see the medial head of gastrocnemius pushing into it. And as you release that plantar flexion and get them to rest, you see the muscle bed come away from the vessels and actually go back to completely normal flow and a normal looking artery. So that is really important in terms of making the diagnosis. So the combination of history with that appearance on duplex scan, for me, is the gold standard in making the diagnosis. So how do we manage it? It really depends on the severity of the symptoms, but I always try and get them to change the type of exercise they do, the duration, the intensity. But honestly, by the time they present to me, they're often so desperate for something to be done that they don't want to do any of this. Occasionally, I think we have to rule out compartment syndromes, and I'll touch on that in a moment. Botox is controversial because I think there probably is a role in these functional syndromes for Botox therapy into the medial head of gastrocnemius, but there's absolutely no evidence. There's nothing in the literature, and there is one ongoing clinical trial in the United States. But I can't help but think it is an area that needs further exploration. Otherwise, we've got surgery, and there are two approaches to this. One is if I think there's an associated compartment syndrome, or occasionally in redo cases, I'll take a medial approach and actually do a full medial fasciotomy, open up the posterior compartments, take down the soleus arch and remove the medial head of gastrocnemius, essentially. Much easier approach is the Popliteal approach. So direct approach, find the artery and remove most of the medial head of gastrocnemius or any associated anatomical abnormalities. It's quite a long post-operative course, similar to the endofibrosis, 6 to 12 week recovery, 10% complication rate. And I think about 80% of them gets full symptomatic relief. But how long that full symptomatic relief for is not that clear. There's definitely a recurrence in around 10%. And I think around 10% have ongoing symptoms that are still bothersome. That just leads me on to exertional compartment syndrome, and it is really sometimes quite difficult to discriminate between these two. I've seen a lot of people recently where it's been quite hard to discriminate between what is clear entrapment syndrome and whether they've also got an exertional compartment syndrome. What is it? You know this, it's just where there's not enough space in the fascial compartments when the muscle exercises, and you get a relative ischemia of the muscle with associated post-exercise edema and lymph dysfunction, which contributes to the edema. They're very similar patients to those I see with entrapment syndrome. So again, young, active, usually bilateral, usually limited to the calf, and it's usually reproducible, but I think perhaps less predictable and reproducible than the entrapment syndromes. It often involves different compartments. So whereas the Popliteal entrapment syndromes almost always start with that deep-seated posterior calf gastrocnemius pain, often the exertional compartment syndromes have different areas involved. So around 50% involve anterior compartment, 25% lateral compartment. And I think there are just subtle differences in the symptoms, but particularly the signs when you examine people. You can often feel, again, I'm sure you see this real tenderness and firmness of the affected compartments, which you don't see with a pure entrapment syndrome. It's often quite painful just putting them through passive stretch and deep palpation of the muscle, which again, you won't see with a pure Popliteal entrapment syndrome. And often I think other injuries. So I often see the MRI scans of these people, and they're quite difficult because they have other things going on. So often quite difficult to pin this down to a single diagnosis. Again, I'm sure you know this, but the classical sort of literature raised compartment pressure figures are greater than 15 millimeters of rest, greater than 30 millimeters after exercise, and greater than 20 millimeters 5 minutes after exercise. Really difficult, I think, to do. Some of you, I'm sure, do this. Difficult to do it in a reproducible way, and I think often really difficult to use it to pinpoint. But if it's grossly abnormal, I think it's really, really helpful. I think it's really helpful, particularly combining that with the duplex ultrasound and an MRI scan of the calf muscles to look and see if they look normal. There is some data in the literature to suggest that nerves, near-infrared spectroscopy, might be useful pre and post exercise, but it's not something we use routinely, but there may be something in that. And again, conservative management probably is the key here, unless it's severe. So looking at biomechanics, icing, non-steroidal and so on. But otherwise, surgery involves fasciotomies, and I've seen good and bad results from fasciotomies. So I think it has to be very cautious and really careful case selection for fasciotomies. But if those compartment pressures are dramatically abnormal, there is a clear role for fasciotomies. In terms of the surgery, the outcomes are about the same as for entrapment, interestingly, from what we know from the literature there is. So around a 10% complication rate, 80% improvement, but less so for the deep posterior compartments. And about the same recurrence rates, around 10%. And just finally, just a couple of slides on this condition, just so you're aware of it, because I see this around once a year. Popliteal adventitial cystic disease. It's the most bizarre condition. We have no idea what causes it, but it's exactly as it's described. You have cysts in the adventitial, the artery, and it's usually really fit, active young men who present with classical calf claudication. And the history is key, but also duplex ultrasound is absolutely diagnostic. You see these cysts in the arteries, which can be confirmed by CT or direct angiography imaging. And treatment for this is surgical. So if you see these, you operate on them before the artery occludes. Because if the artery occludes in a young patient, that's devastating. So that was a whistle-stop tour of the conditions I see and have an interest in. I think for me, the key messages to take away are really careful assessment. The duplex ultrasound is absolutely mandatory, but it has to be done in the right hands. So finding a duplex ultrasonographer who understands these conditions and knows how to provoke for it, and putting that together with the history is absolutely fundamental, alongside the other spectrum of diagnostic tests we've gone through. I think you've got to have a really high index of suspicion. Again, that reflects the poor diagnosis rates in these conditions. Investigate thoroughly. I genuinely feel, and Justin and I have talked about this, having a multidisciplinary approach is essential. Otherwise, I think we all focus on one condition or one side of things. These are classical conditions where actually, if we all put our heads together, I think we'd make a diagnosis quicker and also make a much more effective management plan for these people. Thank you very much. I've just put my contact details on the end of a website if you're interested. Thank you very much, all of you, and Justin.
Prof, thank you very much indeed. That was really, really enlightening, very interesting indeed. I'm going to put that any questions over to the attendees. So just raise your hand, and I'll invite you to speak if there is any questions. Leona. Hi, Leona.
Yes. Good evening, gentlemen. Thank you, Professor Ian. Just to ask, I enjoyed your talk immensely. I did a course on hemodynamics years ago, so it's very refreshing to hear this. But what I wanted to ask was, is in your practice over the years, have you seen any of the conditions that you've said, are they specific to one culture, or is it across the board?
That's a great question. And honestly, it does seem, but I think it's about my referral practice more than anything. There's absolutely nothing in the literature for any of these things. But the patients I see generally, honestly, are white young men. That now, whether that's something about their musculature, I genuinely don't know. And there's absolutely nothing in the literature. But it's the same if you look at the endofibrosis literature. So it's a really good question, and I'm afraid I don't have a really good answer for you, other than it needs a bit more of a look.
Yeah, it'd be interesting to know if that's something, but obviously it's not something that you've seen, but I just find that it's really fascinating. Is it because why you see it in white male, is it because they particularly like sports in cycling, or could that be the reason? What could it be?
Yeah, I mean, interesting that, I mean, it would be worth having that discussion. So the person I mentioned earlier in the States with the biggest experience of the popliteal entrapment side of things and all the related conditions that come with that, gets a huge referral practice. And I can pose that question to him, because so I might actually just ping him an email and see what his thoughts are on there, because it's not something I've thought about in a lot of detail. But actually, it's a really key thing to understand as to whether it's something very specific and whether there are, specific differences in the anatomy or the physiology of this, because some of these conditions must have a physiological basis that we don't understand. Endofibrosis particularly, I think there must be something that we do, but the numbers are so small, we'll never really get to the bottom of it. But if there are very specific background differences in the patients that are getting this, that could be a really important part of our understanding of it.
Thank you. Thank you. Food for thought.
Absolutely.
Great question, Leona. Thank you very much for that. We'll yeah, I'll Prof follow up with me, and I'll put them on the show notes. Thanks, Leona. Mike, I saw your hand had gone up momentarily, but it's come back down again. Any more questions at all? Dan.
Hi, thank you, Prof. That was a fantastic talk, and I feel like I understand it a lot more now. Could you expand a bit on the surgery and the complications? Because it seems like if we diagnose people with this condition and they're pretty high level, they're probably going to want some sort of surgery. And I was just wondering if you could expand on the risks, the rehab, just as a sort of overview. That would be really helpful. Thank you.
Yes, so the other condition I have a particular interest in, which I haven't talked about tonight, is thoracic outlet syndrome. And I think of the recovery and complications from these conditions in a very similar way, because they're such high performing individuals. I always say to them 6 to 12 weeks for recovery. So 6 weeks for normal activity, 12 weeks for high performance activity. That first 6 weeks, I then break it down. For all of these conditions, actually, I break it down into 2-week blocks. And I pretty much say for 2 weeks, you do almost nothing. The next 2 weeks, you do a reasonable amount. The second set of 2 weeks, you try and get back to normal. So it sounds really simplistic, but I think people kind of understand that. It's the 2-week block. So that's the kind of recovery period. The 6 to 12 weeks is that high end, pushing it back to the full level of activity. Complication rates, honestly, for most of these things, actually, it's not major things, it's wound-related complications. So especially for the calf procedures, the entrapment syndromes, the Popliteal approach particularly, they occasionally do get wound problems. So wound infections, wound dehiscence, very occasionally herniations through the fascial layer of the popliteal fossa. Very occasionally, but rare, nerve injuries, and that's specifically to the cutaneous nerves, so patches of numbness, which to you and me might not be a problem, but in a high-performing sports person it can be. And then, of course, I always warn people for all of these conditions, from thoracic outlet to calf, is the potential damage to the neurovascular structures we're trying to protect. And the most, I suppose, the most likely risk there is DVT. So if they, for any reason, we do anything to the vein, or they get bruising around the vein or a hematoma, there is a small risk, probably less than 1%, but 1% risk of DVT, again, in a high-performing sports person is absolutely something they need to understand and be aware of. So serious complications, I genuinely believe, is less than 1%. And the majority are relatively easily manageable. But again, a high-performance individual, a wound complication can set them back 6 weeks. So I'm very clear and specific about warning them of those sort of 1 in 10 wound problems.
And the operation for endofibrosis, when can they get on the bike? Because I imagine getting into that hip flex position is key, but also if they're pretty keen and obsessive character types, they'll want to get on as soon as they can.
Absolutely. And you have to be really careful to stress a slow approach to it. So very gentle cycling, 4 to 6 weeks, but nothing in that hyperflex racing position for 6 weeks at least. Otherwise they set themselves back longer. And again, it's the same with all these conditions, including the thoracic outlet syndromes. If they push themselves too quickly, too soon, they set themselves back far further than they are going to make progress. So I think they have to be very, very cautious, especially the endofibrosis, actually. but also the popliteal entrapments. If they push themselves, they start running too quickly and they get a hematoma or they have a fascial hernia, they can set themselves back months. So they've got to be very, very cautious. Just touching on the surgery itself, I didn't really go into detail, but the popliteal entrapment is really, it's the most bizarre surgery really, because it is essentially just cutting out muscle. I mean, that might sound weird, but honestly, I've become quite brutal with it now, almost orthopedic. Just literally take out most of the medial head of gastrocnemius for these functional ones. And the more I take out, the better the results. So it's not complex surgery, but it is quite a complex recovery, complex diagnosis, complex recovery. The surgery itself is actually not that difficult.
Prof, has anybody done any, if you're removing that much, so removing medial heads, anybody done any dynamometer work to see what difference there is in power after, pre and post-op?
No, I mean, there's so much science that should be done around this that we just have never got around to doing. It's exactly the kind of thing we should be doing. I mean, what I've tended to do is actually try and follow these up for as long as possible and just try and see how much close to their normal pre-symptoms activity they can get. So, but again, this is often go back 5-10 years and they often can't really remember. Okay. But I like to know, how far are they running? Simple questions. So if they come to me and they can only run half a mile, but they're running 20 miles, to me, that's a really good result. But no, there's so much science for all of these conditions that we should be doing, but because the numbers are so relatively small and they're spread out across a number of centres, it's really hard to actually get the numbers to put some science behind it. But it's a shame.
Dan, good. Any more questions? You're on mute. Perfect. I'll turn you off there, Dan. And who'd we had? Mike Rossiter. Just unmute, Mike. You're on. Perfect.
Can you hear me now?
Hi, Mike.
Yeah, sorry, I had trouble with my microphone earlier. Techno numpty. Ian, thank you very much for that talk. Very, very interesting. I suppose a little bit of an unvascular question, but going back to your surgery for compartment syndrome, I'm always very interested in the recurrence of compartment syndrome. And I just wonder why you think there's a recurrence. Is it that there's something else coexisting, or is it the type of decompression that you do? So is it a fasciotomy or fasciectomy that's actually a better surgical option?
I think you've just answered the question. So I think it's often inadequate surgery. So certainly when I do compartment releases, I get pretty aggressive with it. So you've got to absolutely release the whole of the fascia, top to bottom, in my opinion. But also, I think, again, you've touched on it, I think there are often other conditions here. So it's not just compartment syndrome. So I think really careful diagnostics to try and work out whether there are associated conditions, especially the popliteal entrapment syndromes, because I see quite a lot of overlap between these two. But if you're going to do compartment releases, doing them properly, i.e. a full compartment release, so any scar tissue that forms doesn't create a further compartment pressure issue, because I think redo compartment releases have a really poor prognosis.
Thanks. Does that mean then that pre-compartment surgery, you would always do a full vascular workup?
I would always do the duplex ultrasound. That's the key for me, because in the right hands, it's so easy. I mean, I guess I have easy access to it, but and I do some of it myself. But for me, it is such a simple, non-invasive test that for all of these patients with exertional calf symptoms, why not do it? It takes 10-15 minutes. It's got to be in the right hands. That's the key. So doing them in the right hands and directing the person doing the scan to the symptoms. So, I have one particular guy I work with who does a lot of ultrasound with me, and I go and explain the symptoms to them and say, look, I think this is what's going on. Can you look out for this particular problem here? So you kind of guide them. But yes, I think we should use duplex ultrasound far more often, and probably before MR scans and all, the other sort of plethora of tests that we have available to us.
Great, thank you very much indeed.
That's right. Just leading on from that one, Prof. So the duplex is in plantar flexion and you're looking for that compression of the popliteal artery. If it isn't there in plantar flexion, because a lot of if we went into tiptoes, they wouldn't necessarily get the symptoms. It's always that running related symptom. If it's not there, what's the sensitivity of that?
Yeah, so they're the ones when, if I'm still suspicious from the history and the history and the examination findings, then that's when I start to do MR in different positions or direct diagnostic angiography, because I do miss some. So some of them, and especially some of the slightly more unusual entrapment syndromes, which I haven't got into detail actually, just for time tonight, you can see problems on diagnostic angiogram where you've got much better ability to do different positions. You can actually, and some people will say to you, if I go into this position, that's when I get my symptoms. And you can actually reproduce that in angiography, which you can't necessarily do in duplex quite the same way. So sometimes in those ones where the duplex doesn't potentially give us the answer, combining the duplex with an angiogram or an MR angiogram can be really useful.
Okay, that's really helpful. Mike, thank you for your question. Ali Nicol. Ali, evening.
Evening, Justin. Thanks very much. And thanks very much, Ian. Thoroughly enjoyed your talk. I think I sent you several patients over the years from Headley Court, most of them popliteal. But my question is about the endofibrosis, which you don't see that often in the military. Is it just, do non-cyclists get endofibrosis? And if they don't, then I think you mentioned in your provocative exercise testing, a treadmill. Why put them on a treadmill if they only get it in flexion?
Yes, very selective people. So it's by far the majority are cyclists, and it's that hyperflexion position. There are descriptions in the literature, but I think very rarely seen of it in other athletic sports. But certainly I've never seen it in non-cyclists. But you do occasionally get people who do Ironman, for example, who will say, who are doing high-end running and cycling and swimming, and they'll say it comes on with swimming, with the cycling and the running. Okay. And in those, you might put them through both, just to try and see if, they both reproduce the same flow disturbance in the iliac artery. But it is certainly, from what we know clinically and from the literature, it is by far the majority in these very high-end cyclists.
Great, thanks very much.
Thanks, Ali. Prof, you mentioned DVT and sort of slightly different from what we were discussing, but for those high-level athletes who'd got a DVT, how long before recanalization would occur and normal flow dynamics would occur within a lower limb after that sort of significant DVT?
It depends on the extent of the DVT. So localized popliteal vein is actually relatively benign. If it spreads north towards femoral vein and further, then it can be much more disabling and much longer recovery. So localized popliteal vein DVT actually should have relatively mild symptoms and should recover quite quickly, especially if diagnosed quickly. But if it's missed and diagnosed late and it's spread and they've got an extensive DVT, honestly, it can never recover. So some of them have permanent problems with post-thrombotic limb. Not so much in this cohort. I've never seen a long-term post-thrombotic limb in one of these patients. I've seen it from unrecognized popliteal venous entrapment, where they've had an extensive DVT, and you get these rare iliac vein syndromes as well. Again, I haven't really touched on those just for time reasons, where they get an iliac vein thrombosis, and that can be very disabling. And we're quite aggressive in managing those now, sometimes lysing them and stenting them open. But yeah, it's all about the position and the extent of the clot as to what the long-term sequelae are.
Great, thank you very much. Ali, your hand's still up there. Is there another question? Yeah,
sorry, Justin, I did put it down again. I have got another question, and my apologies for stealing the mic. So you just pick up on something you said about surgery for popliteal artery, and that it wasn't that technical. And maybe I'm paraphrasing, but if that's the case, why shouldn't we try Botox first?
I think we should. For me, it's about trying to find someone who's prepared to do it. I've always been a bit reluctant to do it because I've never injected Botox anywhere else. It's just not something I've ever done. It's really easy to do. I mean, you see on that ultrasound how easy it is to see the medial head of gastrocnemius. So technically, it must be the easiest thing in the world. But I have no idea what the long-term effects of that would be. I mean, if I cut most of the medial head of gastrocnemius out, clearly that's pretty, going to have important consequences. But if I inject Botox into it, I have no idea what it's going to do. And that's just my slight hesitancy. But I would love someone to do it. So if anyone out there wants to have a go, I would genuinely refer patients to you to do it. It's something I just don't feel quite comfortable doing myself, just because I've never done it. I've never injected Botox to anyone.
Is the fasciotomy that you do simultaneously with posterior artery entrapment syndrome in those with high pressure is the exact operation that foot and ankle would do for posterior chronic exertional compartment syndrome?
It depends. So when I do it for popliteal entrapment, I tend to just do the medial approach and release all the posterior compartments. So I won't release the anterior compartments from the lateral side, and unless there is a very clear anterior compartment syndrome as well. And they're few and far between, actually, to have the whole package. So I tend to focus on those by doing the medial approach with literally full length, top to bottom fasciotomy, and completely open up the whole of the posterior compartment through that medial approach. But it's quite a big thing to do, actually, and they do take quite a while to recover from.
Okay, well that wraps it up. Prof, thank you so much. A nice bottle of wine on the way to you, and but that was really useful. And so, as Prof's specialty area is of many specialty areas, certainly exercise-induced leg pain and what we discussed. Very kind to put the details on there. Similarly, Prof, if there's stuff that we can help with as a group and a specialty, we're always very happy to help. If you just email one of us, we're very happy to work together. And
Perfect.
but thank you so much for your time this evening, and thanks everyone else for logging on. Enjoy the rest of your evenings, and have a great half term. Thank you very much.
Thank you very much.